today we will focus more on anatomy and the clinical cases rather than a lot of embryology. So I will just touch embryology, which is clinically relevant. So coming with the case, we know foot drop is quite common entity in our neurology practice and our neurology OPD also. And we know when patient come with a foot drop, our diagnosis is either L5S1 radiculopathy or it is a common peroneal palsy. So this 51-year male presented with 3-month history of progressive difficulty in walking, and he was having high stepping gait, so he had right foot drop. There was a chronic backache, and the right ankle dorsiflexus was 2/5, and EHL was weak. So as usual, when there is foot drop, first our investigation is nerve conduction and the MRI. So MRI LS spine was done, and there was no significant compression of L5S1 root. Axial cuts also show no compression. So now conduction study was done, and the now induction study shows that right common peroneal nerve was not stimulable. Left also show decreased CMAP. Rest of the conductions was normal. So diagnosis of L5S1 radiculopathy and common peroneal palsy was kept. But still, what the cause of this is not very clear. Etiology was not well defined, and this patient came to our OPD. And when we re-evaluate it, we find that the knee and biceps were also brisk. So possibly this jerk was ignored by the previous workup. So because the upper limb as well as knee jerk were brisk, we advise for MRI, cervical and dorsal spine. And now we can find there is a flow words in the cervical spine and upper part of dorsal spine. So this is the axial cut, and we can see there is a lot of cord edema, and there is a very prominent flow void because of perimedullary network. And these vascular flow void was extending from C7 to D8. So we advise CT angiography. We try to find out the level of feeders from the CT angiography. MR angiography is one of the very good tool, but we are comfortable with the CT angiography. So we done CT angiography, so we can find there is a tortuous dilated vesicle network here. This is dorsal spine, and upper dorsal and mid dorsal has also prominent tortuous vessels. Again, you can see in the axial cuts there is a very prominent vessels here. And this is the axial cut at level of D7, D8. And we can find there is a prominent vessels more on the right side, So possibly we expect the feeders from the right side. So we went ahead with the DSA. So this is our Cobra catheter at level of D7. This is radicular artery, and this is the site of fistula, and these are the perimeter veins. So we discussed this angioarchitecture in detail. So how to treat this patient? To understand this, we should know about radicular artery anatomy, and we should know about segmental artery and metameric artery. So that is about the fetal development of the spinal cord. Yesterday, Dr. Deep discussed very well these points. So I will just have a brief discussion about this. So in the first few weeks of embryo, there is a 31 somites, and you know what is the 31 somites from the rostra to quadrant direction. And these somites are correspond to the 31 pairs of the spinal nerve, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 5 coccygeal. So at each level, these somites are supplied by the vessels, and these vessels are supplying to the ribs, muscles, etc. So there is a 31 metameric artery. These are called metameric arteries. So total there is a 62 metameric artery. These metameric or segmental arteries supply to the all ipsilateral derivative of corresponding metamere, and these metamere are neural crest, neural tube, somites, which ultimately forms muscle, skin, bone, spinal and spinal cord. So again the same diagram. So at each segmental level or at metameric level, these vessels are supplying, which are supplying to the all derivatives of metamere. But as embryo grows, what happens? Some of the vessels disappear. So most of the vessels regress over the time, and only few vessels remains. So you can see there is metameric vessels or segmental vessels. Now this vessel has regressing, this vessel is regressing, and some vessels are connecting and forming in the midline. So at the end of the embryological development, 62 metameric artery will, most of the vessels regresses, and only the 4 to 8 vessels will supply the ventral spinal axis or anterior spinal artery, and 10 to 12 dorsospinal or pile artery or postspinal artery. So you can see this is the metameric supply, and when the embryos develop, then only few vessels remains here. So it connect to the anterior spinal axis, which ultimately is the anterior spinal artery, and there are some pile vessels also, that is postspinal artery. But this regression is more in the caudal direction. So there are more vessels in the cranial, but as you go down, the vessels become less and less. So more regression occurs in the caudal than the cervical region. That's why you have good supply in the cervical region to the spinal cord, to the costocervical trunk, thyrocervical trunk, and thoracic area or lumbar area. There is very few blood supply. We know there is one prominent artery, that is artery of Adams-Hughes. But this area is less supplied, and this area is distally supplied. So these are the major artery trunks supplying the radicular artery at each level. So we know that this is the ventral spinal axis, which is formed by the joining the anterior spinal artery origin from the both vertebral artery. They join together, from the, they run in the center line. So because this ventral spinal axis is very, very thinned out, so it has to be enforced by the various vessels. So these are the various enforcing vessels which enforce the anterior spinal axis. Vertebral artery, thyrocervical trunk, branch is ascending cervical artery, costocervical artery, branch is deep cervical artery, then occipital artery and ascending pharyngeal artery. At thoracic level, again it is a costocervical trunk branch, supreme intercostal artery, which is branch of the costocervical trunk only, and the internal thoracic branch of the subclavian artery. So these are the enforcing artery at the level of thoracic level. At the lumbar artery, there are lumbar branches, medial sacral artery, lateral sacral artery, and iliolumbar artery. So these are the sacral artery. Main artery is the medial sacral artery, lateral sacral artery, and the iliolumbar artery which supply the lumbar region. So what is the radicular artery? Radicular artery is the artery which supply to the nerve root, and some of the radicular arteries supply to the spinal cord. So for this example, this is the aorta. From aorta, this segmental artery is arising, and this segmental artery giving branch to the somites. So it will supply to the nearby bones and skins, etc. But this artery further advances and supply to the nerve root. So the branch which supply to the nerve root is called radicular artery. There is a two radicular artery, ventral and dorsal. So there is a radiculomeningeal artery which is dorsal, and ventral radiculomeningeal artery. So basically we have three types of radicular arteries. One is called radiculomeningeal artery, which supply to the dura and the nerve tissue at segmental level. Then we have radiculomedullary artery, that is anterior spinal artery, and radiculopyle artery, that is postspinal artery. So what is radiculomeningeal artery? Which supply to the nerve root. So this is aorta, this is segmental artery, either intercostal level or lumbar level, and which is going ventrally and going dorsally. So it is supplying to the dura and the nerve root. So that is called radiculomeningeal artery. Then we have radiculomedullary and radiculopyle artery. So we have seen this is the radicular artery. It is a radiculomeningeal artery which is supplying to this nerve root. Then we have a radiculomedullary artery which is supplied to the anterior spine axis. So that is anterior spine axis. So the vessels which supply to the anterior spine axis is called radiculomedullary artery or anterior spine artery. At this level again we can see the vessel is radiculomedullary artery because it's supplying to the anterior spine axis. At the same time it gives branches to the posterior lateral part of the spinal cord. So they are called radiculopyle artery. So we know that there is two radiculopyle artery and one ventral spinal axis. So one anterior spinal artery and two posterior spinal artery. So this is about the radiculomeningeal artery, radiculomedullary artery and radiculopyral artery. Again, in this diagram, this is radicular artery, this is radiculomedullary artery because it is going to the ventral spinal axis and then enters into the spinal cord through the sulcocommissural artery. We will discuss in detail what is sulcocommissural artery, and it is very, very important to understand this sulcocommissural artery and its branches, because particularly when we are embolizing through the anterior spinal artery, this is our safeguard to understand this anatomy. And this is radiculopyral artery, which is supplied to the posterior spinal artery, and there is a two posterior spinal artery. So coming to the radiculomedullary artery, so this is radicular artery, this is antispinal artery, and it is entering into the spinal cord through this sulcus, and this is sulcocommissural artery. So this is sulcocommissural artery, and which gives supply to the anterior two-thirds of the spinal cord, mainly the gray matter as well as the white matter of the anteriorly. It is a dominant supply to the spinal cord. There is 2 to 4 radiculomedullary artery in cervical level, 2 to 3 in the thoracic level, and 0 to 4 in the lumbosacral region. They are very small. The diameter varies from 0.2 to 1 millimeter. So this is the ventral spinal axis we have already discussed, and this ventral spinal axis is reinforced by the radiculomedullary artery at the various levels. That is thyrocervical trunk, costocervical trunk, and then we have the main artery, that is called artery of Adamski's. So what about artery of Adamski's? Because it is main antispinal artery. So this is artery of Adamski's. There is a shape is hairpin turn, and you can see this is a antispinal axis, very thin antispinal axis. Usually it arises from D9 to D12 level in 75% of cases, but in some of the cases it may arise above the D9, that is above D8, or sometimes it may arise below the L2. When the anterior spinal artery or Adamski's is arising above D8 or below L2, there is another anterior spinal artery which reinforces it, because this is the common level, but sometimes it is arising above or below. Then there is a two anterior spinal artery which reinforce the spinal cord. We will see some of the examples. And in 30 to 50% cases, these artery or Adamski's also give supply to the posterior spinal artery. So it does not give only to supply to the anterior spinal artery, it also gives some contribution to the dorsolateral pile system or paired posterior spinal artery. So what about radiculopyral artery? So this supplies the nerve root and the pile network, or this is the pile network, and these are the two radiculopyral artery, and they anastomose with the anterior spinal artery. 3 to 4 in the cervical level, 6 to 9 in dorsal level, and 0 to 3 in the lumbosacral level. They are thinner than the radiculomedullary artery. The diameter is 0.1 to 0.2 millimeter. This is the anterior spinal axis, anterior spinal artery. These are the posterior spinal artery, and these anterior spinal artery and the posterior spinal artery are connected through one of the network, what is called vasa corona. So the connection between the anterior spinal artery and posterior spinal artery occurs through the vasa corona. Then we have two systems, centrifugal system and centripetal system. So the anterior spinal axis follow the centrifugal system. So this is ventral spinal axis, this is radiculomedullary artery, and these are the sulcocommissural artery. And these sulcocommissural artery are two, one for the right side, one for the left side. And there are around 200 to 400 commissural artery within the ventral sulcus of the spinal cord. So this is the ventral sulcus, and these are the sulcocommissural artery. And they mainly supply they are in the gray matter of the spinal cord, and they supply majority of the gray matter as well as the ventral half of the spinal cord. They are very thin, the diameter is 0.1 to 0.2 millimeter only. Then we have centripetal system, which is for the posterior spinal artery. So there are two posterior spinal artery, and they are supplied to the dorsolateral of the spinal cord. The white matter and portion of the gray matter of the dorsal horn is supplied by these posterior spinal artery, And as I told previously also, this post-spinal artery and anti-spinal artery communicate together through the vasa corona. Then we have the spinal venous system. Venous system is very similar to the arterial system. So we have anti-spinal vein, we have post-spinal vein, and these anti-spinal vein and post-spinal vein communicate with this great radicular vein or perimeter vein. And this connection is through the radicular anterior vein and the radicular posterior vein. So again, we have anti-spinal vein, we have post-spinal vein, then we have radicular anterior vein, radicular posterior vein, and then they drain into the great radicular vein, and ultimately this great radicular vein drain into the epidural venous plexus. This is the venous system, very similar to the arterial system. So we know this is anti-spinal vein. This is the sulcus. This is the sulcocommissural vein. This is the anterior or anti-spinal vein, and this is draining into the ventral epidural plexus. These are the two posterior spinal vein. This is the 1 and 2. These are the posterior spinal vein. Ultimately, they are draining into the radicular vein, and these radicular vein ultimately drain into the posterior epidural space. So there is the anterior epidural space and the posterior epidural space. So this is one of the DSA in our lab. So this is at the level of left D10. So this is our cobra catheter in left D10. This is segmental artery. This is radiculomedullary artery. Why it is radiculomedullary artery? Because it is supplying to the anterior spinal axis. So it is classical hairpin turn, and we can see this straight line that is called ventral spinal axis. This is the venous phase of same angiogram, and we can see these are the perimedullary vein. This is one of the DSA in 17-month child, and we suspected vascular malformation, but ultimately it was not vascular malformation, but it was a prominent radiculomedullary artery. So it is a level of left D4. This is our catheter, and we can see classical hairpin turn. Vessels are very prominent here, possibly it is because of children. This is anti-spinal axis, and this is post-spinal artery. So anti-spinal artery ending here. This is a post-spinal artery, and both are connected with the vasa corona, or what is called basket. So we can see here in this angiogram, this is a post-spinal artery, this is anti-spinal artery, and both are connected to the basket. And we think possibly this is a non-compressive myelopathy, and more patient will improve, but suddenly patient deteriorates. So this is one of the indicators for the dural fistula, and possibly these flow voids was not looked properly. So this is a better MRI, and you can see there is a lot of flow voids on the surface of the cord, and there is a cord edema. There is a long cord edema, and there is so that was missed by the treating physician. But why the corticosteroid deteriorate this condition? The reason for this is because of the fluid retention. We are giving steroid with a saline infusion, which lead to the further venous engorgement, and they exacerbate the spinal cord edema, resulting into the neurological worsening. So this is the one of the point you must remember. If any patient on steroid deteriorates, then it is a spinal dural fistula. So how to treat? Either you do endovascular treatment or the surgery. Both are good option, but the aim is you have to occlude the fistula, and you have to occlude this proximal part of vein, what we call as a foot of vein. So our embolic material should reach this fistula as well as foot of the vein. Then only we can say it is a cured fistula. The success rate of endovascular therapy is around 50%. Most of the patients are diagnosed very late. In spite of that, they improve, but they improve partially because some are diagnosed after many years. So what we expect after complete occlusion of fistula, progression of disease may ease. In 2/3 of patients, there may be improvement in the motor power. It may be significant or it may be partial. In 1/3 of the cases, there may be improvement in the sensory disturbances, but sphincter disturbance and impotence seldom become reversible. So coming to our original case, the case which presented with the foot drop and have this serpiginous lesion. This is the DSA and this is the cobra catheter at the level of T7 intercostal artery. This is a radiculomeningeal artery because it is supplying to the nerve root, and this is site of fistula. This is radicular vein and this is perimedullary vein. So our target of treatment is occluding this fistula and getting some proximal part of the vein. This is the lateral view, and it is always very, very important to take lateral view to know where the fistula is. It is ventral or it is dorsal. So here we can find it is a dorsal. So this is our microcatheter in the fistula, near the fistula in the radiculomeningeal feeders. This is the lateral view. And we place the glue. This is our glue cast in the part of the vein and in the radiculomeningeal artery. I think better appreciate glue in this CT. So this is follow-up CT scan, and you can find the glue cast in the fistula and in the proximal part of the vein. This is follow-up MRI after 6 months. We can find the glue cast here, and what we can appreciate that the quad edema is completely subsided and there is no phloboids in the surface of the quad. So the power after 6 months improved from 1/5 to 3/5, and there was a relief in back pain. So there is a preambulation. You can see there is a phloboids, there is a no phloboid, and as well as there is a no sign of venous hypertension in form of quad edema. This is pre and post MRI. So you can find there is a lot of quad edema here. Now the quad edema has subsided. This was the prominent perimedullary vessel, now which completely disappears. This is follow-up CT angio, maybe after 1 year, and now power improved from 1/5 to 4/5. So this is pre and this is post. So this you can see there is a glue cast. Now you can not find this serpiginous lesion which was previously there. So this is the first case. Coming to the second case, 55-year male, paraparesis for 6 months, and we can find there is a phloboids here along with this quad edema. So here feeder was at left D10. So this is intercostal artery at D10. This is radiculomeningeal artery. This is fistula, and this is draining vein. Before we are planning for treatment of fistula in DSA, we must find where is the artery of Adamski. So the fistula was level of D10, and this artery of Adamski was at level of D9. So you can find this is the hairpin turn of the radiculomedullary artery or artery of Adamski, and that is anti-spine axis, very faintly visualized here. So we placed microcatheter near the fistula and glue embolization was done. So this is the glue cast in the fistula and the proximal part of vein, and this is after embolization. And here the power improved from 2/5 to 4-5 within 3 months, and patient was able to walk with support. Another case, 45-year female, and she had hyperacute paraplegia. The power becomes 0/5 within 5 hours. So sometimes it has very acute presentation, sometimes it is indolent course, it's not diagnosed for many years, and sometimes they present with the acute course. So here patient become completely paraplegic within 5 hours. The sensory level was at D10, and there is along with there is a posterior colon vomit. So this is the spinal angiogram. This is the radicular artery, and this is radiculomeningeal artery, and this is the site of fistula, and this is perimedullary vein. So this was the site of fistula. Yeah, so this is site of fistula here. So the microcatheterization was done up to here. We could not reach exactly to the fistula, so we thought that we will inject the squid here. So embolization was done with squid 12, that is phenyl alcohol. So this was the site of fistula, and this is all the squid cast. So squid cast is there in the fistula as well as in the proximal part of the perimedullary vein. Another case, 68-year female with paraparesis for last 6 months, power was 1/5, and MRI you can find, in contrast MRI you can find some prominent vessels here. So it was spinodural fistula at level of D7, D9, and so this is catheter is at level of D7, D9. So this is radicular artery, radiculomeningeal artery, this is site of fistula, this is radicular vein, and this is perimedullary vein. And here the anterior spinal artery or the AIIMS was arising from the left D9 below that level. So it is very, very important to identify the level of the anterior spinal artery also, because if it is arising from the same level, then we may have difficulty in embolizing. So this is site of fistula, this is radiculomeningeal artery, fistula, radicular vein, and the perimedullary. So this was planned for embolization. These are the AI generated photos on the GE machine. So you can keep one cursor here and it will tell where, because sometimes there are multiple arteries are visualized and sometimes very difficult to find which is basically radiculomeningeal artery. So this definitely helps in planning of the embolization. So this is intercostal artery, this is radiculomeningeal artery, and this is site of fistula.
This is a 3D image?
These are 3D images, yes. So this is site of treatment, site of fistula. So we can place microcatheter up to here, and we occluded this fistula. This is the squid cast, again with the squid. So this is the site of fistula. This is perimedullary vein, this foot of the vein, and this is our radiculomeningeal artery. So this squid is exactly lying at the site of fistula and the proximal part of the vein. So this is the squid cast, and here power from 1/5 improved 2/5 in 3 days. Another few of cases. So 62-year male, paraparesis for 1.5 years, so he was diagnosed late, and power was 3/5. There are some flow voids are visible here, not very apparent. And this is a spinal DSA. So this is cobra catheter at level of D6, and you can see spinal dural fistula. But what is more important, you can see the anterior spinal artery. So you can see this anterior spinal artery clearly. So at D5 there was an anterior spinal artery. So with one injection we can see both radiculomeningeal artery and the fistula. But at above level we can see there is a anterior spinal artery. So it is again very, very important to identify the anterior spinal artery, and luckily we could find with a single injection this radiculomeningeal artery and this radiculomedullary artery. So definitely we have to avoid this artery for catheterization. But as I told initially that because here the radiculomedullary artery arising from D5, as I told that usually the AIIMS arises from D9 to D12. If it is not arising, if it is arising above, there should be another anterior spinal artery to supply the cord. So because it was arising very high and it was on the right side, so we could find there is another anterior spinal artery in this case at the level of left D8. So there was two anterior spinal arteries, one at was the D5 and at the right side, and another was the left D8 on the left side. So that you can find, and this is the anterior spinal axis.
So suppose you would have found the later one, would you have still searched for another one?
Yeah, definitely I will search.
So if you find
If it is arising from aberrant position, it is not usual position for the AIIMS to arise.
that is fine.
Yeah.
But at the first injection, if you had found the second one at the proper place, would you have still
No.
for the second one?
No, but at least as a dictum, we go 2 level above, 2 level below. So even we found the fistula, at least we have to go, because sometimes there is a multiple feeders. So at least 2 level above, 2 level below is the dictum.
Do you start from above down, sir, or go from below up?
Most time we are guided by the CT angio, we told, but sometimes it is a blind. So is not fixed rule. Where find the maximum flow voids are there, and if the CT angio is telling the level is around that, we first go there. The level may be up, level may be down. So it is not fixed formula. Where the maximum flow voids are there, we try to go from there. And then definitely above and down. At least 2 level above, 2 level, where we found the fistula, 2 level above, 2 level down, and at least we try to find anti-spine artery. At what level it is arising. So at least one anti-spine artery is very important to find out. So this was the right D6 feeder. This is our cobra catheter. This is intercostal artery. This is a radiculomeningeal artery, and this is fistulous site. This is a radicular vein, and this is the perimeter vein. So the target of treatment is this fistulous connection. This is the lateral view, and as I told, the lateral view is again very important to find where the fistula, dorsal or ventral. So here it is dorsal. 3D view, I am showing this is site of fistula clearly. Same, you can see this is radiculomeningeal artery, this is site of fistula. So again, we apply for plan for embolization, so we can find this is the way to go. This is the way to go to the site of fistula. Here again we place our catheter more proximally. We tried to find place our catheter, but we could not find more distally even after the nimodipine infusion. So we embolize from here only, but our groove or squid penetrated the fistula very well. So here it is a foot of vein. If you see, this is the fistula, this foot of vein, and this is our squid cast in the fistula and the foot of the vein. So fistula was completely occluded. Another 2 last case, very interesting cases, because these are very, very rare, and it's very difficult to find out these type of fistula because they are supplied by the sacral arteries, and they are very easily missed on good DSA even. So 63-year male, quadriconus syndrome, you can find the venous congestion here and some subtle flow voids here. So this is lower part of aorta, this is common iliac artery, and from here the medial sacral artery is arising. So this is medial sacral artery, and this is supplying to the fistula. Because we often ignore these sacral arteries and sometimes these fistulas are missed. So this is lower part of aorta, this is common iliac artery, and from where the medial sacral artery arises. This is internal iliac artery, and you can find this is the lateral sacral artery, and this is the iliolumbar artery. So sometimes we are not able to find the fistula, we have to categorize medial sacral artery, lateral sacral artery, and the iliolumbar artery. So this is our catheter, and this is site of fistula. More zoom view, not very difficult to reach this fistula, but yeah, it was diagnosed, and surgeons say that they can operate very easily at this level. So ultimately, if patient was operated rather than embolized. Last case, another interesting case of sacrospinatus fistula supplied by the lateral sacral arteries at L5S1 level. So this is iliac artery, this is lateral sacral artery, and you can see this is the fistulous connection, and this is the draining vein. So this is again anatomy, this is medial sacral artery, this is lateral sacral artery, iliolumbar artery, and this is drained by the phylum terminal vein. So this was the site of fistula, this is the draining vein. So microcatheterization up to here, not exactly here, but it was proximal segment, and we injected glue, but luckily the glue penetrated up to the fistula. So this is pre-embolization, this is post-embolization. The fistula completely disappeared, and patient made clinical recovery. But spinal vascular malformation treatment is always challenging, and there's a lot of technical difficulty, and a lot of time I have to call in between the procedure to Dr. Rahul or even Dr. Deep Das that helped me out. And so this is one of the case which is relative contraindication for the endovascular treatment. So this is one of the case where the radiculomeningeal artery is supplying to the fistula, but at the same time the anterior spinal artery is arising. So here the anterior spinal artery as well as the radiculomeningeal artery are arising from the same level. So these are the relative contraindications. Yes, you can do. Dr. Rai suggested me that it is not very dangerous. Just go to the radiculomeningeal artery, the radical anterior spinal artery are arising from very far. But I was hesitant to do embolization in this case, so I referred this case to surgeons. The another main problem in the embolization is this angle. So this is our cobra catheter, and this is a radicular artery at acute angle. So when you try to place your micro catheter here, it will go down rather than going up. So this is one of the very common problems we face. So for that we require some special catheters. So these are the take 4 French C1 Cobra over 032 wire. You can take 4 French Cobra glide cath. SIM2 catheter is difficult to engage, but once it engages, then it is very stable. Cobra engages easily, but difficult to remain stabilized. Whenever you place the micro catheter, it will jump out. SIM difficult to catheterize or difficult to engage, but once it's engaged, it is very, very stable catheter. And as I told that sometimes vessels are so narrowed and you have to give intra-arterial nimodipine through the micro catheter to go to the fistula. So this is our experience for last 12 years, total procedures, and 7 cases the surgery was opted because of contraindication or because we are not able to reach the fistula, and ultimately the surgery was opted. So around we have also 66%, 70% of the duropistula, glomus and juvenile around 21%, perimedullary 11%, 1 case we have final terminal. Along with this, we have some tumors also where we do the pre-surgical embolization like aneurysm bone cyst, hemangioma and hemangioblastoma. So it is very true for spinal as well as all the neurovascular intervention by the legionists. Learn the anatomy, it is the cheapest way to being safe. So I think we have to learn the anatomy, otherwise we will end up with the complication and we will use so expensive devices, sometimes very difficult to explain, and particularly when there is a complication. So cheapest way to do the procedure is learn anatomy. And I thanks Dr. Gandhi, who is part of our team, and Dr. Rahul and Dr. Deep for inputs in various cases. Thank you very much.